Assalamu alaikum. I am Dr. Safdar. I am back to you again with a new topic in urology, that is carcinoma of the bladder. This is just to refresh our memories that these are the ureters and this is the bladder area just above the urethra. If this is a slide showing various cancers, the prevalence of various cancers in the United States is a bit 5 years old data, and the bladder cancer is on the 7th in the list. Unfortunately, we don't have cancer registry in our own country, so we have to take reference to the developed countries. So it is not uncommon cancer, it's 7th on the list. So the population of America is about 1.5 times that of Pakistan, and there are about 75,000 new cases each year. 75,000 new cases of bladder cancer each year. So that makes about 4.5% of all cancers. Cancer death is around 15 or 15,580 per year, and the survival per year 5-year survival rate is about 77%. And if we break these cancers gender wise, men have got more bladder cancer as compared to females, and it's about 3 times more common in men as compared to females. Signs and symptoms is the hematuria, blood in the urine, frequent micturition, painful micturition, and low backache sometimes. Various risk factors associated with bladder cancer: use of tobacco, especially smoking cigarettes, having a family history of bladder cancer, being exposed to certain chemicals in the workplace, like the tannery and people who work on rubber factories. They are more prone to develop bladder cancer. Past treatment with certain anti-cancer drugs like cyclophosphamide or ifosfamide or radiation therapy in the pelvis may give rise to development of bladder cancer. Drinking well water that has high levels of arsenic is also responsible for bladder cancer. Having a history of bladder infection, including bladder infection caused by schistosomia, hematobium in the area like Egypt. The most common cause of bladder cancer is schistosoma hematobium, and it leads to formation of squamous cell carcinoma instead of transitional cell carcinoma. And if the urinary catheters are used for a longer time, it also leads to formation of or development of bladder cancer. So special investigations which are indicated is ultrasonography, intravenous urogram, CT or MRI, and cystoscopy. So this is how the bladder cancer looks on ultrasonography. This is a clear picture of a normal looking bladder. It has got a smooth bladder outline, and here there is a mass inside the bladder on ultrasonography. There is another small seedling here on the left lateral wall. And this is a normal looking kidney on ultrasonography. This is the liver, so this is right kidney, and this is obstructed kidney. Sometimes the bladder cancer leads to obstruction of the ureter, so there is back pressure and the hydronephrotic kidney. So this is liver and this is obstructed kidney. This is the normal cystogram of a person, and this is how there is a filling defect inside this cystogram. This is due to bladder cancer. This is a blackish shadow or the filling defect. So histologically, more than 90% of the cases, it is the urothelial cancer arising from the urothelium. Squamous cell carcinoma occurs in 3%. The two or three most common causes is infection by Schistosoma hematobium, or the bladder stones. They lead to formation of squamous cell carcinoma, or the long-term castration. Adenocarcinoma, it's about 1.4% of the cases. It usually occurs in cases of bladder diverticulum and small cell cancers. Next investigation is CT scan. This is how the bladder cancer looks on a plain CT without IV contrast. So this is bladder, and this is, there's a mass on the left lateral wall, and this is how it looks on when the patient is given IV contrast. So this is the contrast inside the bladder, and this is the filling defect, and this is again CT scan with contrast. This is the contrast, whitish is a contrast, and this is grayish is the bladder tumor. So there is another question whether to go for CT or MRI. MRI give a bladder tissue resolution as compared to the CT scan. So for soft tissue, MRI is better than CT scan, but availability of MRI is a bit difficult than as compared to CT scan. CT or PET scan. PET scan has got a better sensitivity and specificity than the CT scan. This is the plain CT, and this is the bladder tumor, and this is how it looks on the, this is the normal bladder, and this is the hole is the cancer. Just compare. This is how it looks on the CT. This is blackish or more gray is the normal bladder, and this is the less gray is the bladder cancer. This is on CT, and this is how it looks on the PET. So PET gives a better resolution, PET scan. And number fourth diagnostic is the cystoscopy. By putting in the cystoscopy, a cystoscope inside the bladder, one can see the visualize the bladder tumor, and one can also resect it as well. So diagnosing bladder cancer, usually a cystoscope and biopsy will be done. There are three types of bladder cancer, but most people will have transitional cell or urothelial. 90% of the cases it's a transitional cell carcinoma. There are two other things very important. One is the grading, and one is the staging. Staging is the depth of the tumor. How much deep is the tumor inside the bladder, that is called grading, and staging is how anaplastic the tumor cells are. Normally the grades are 1 to 3, and the stage 1, 2, 3, 4. So stages of bladder cancer, basically how deep has the cancer invaded into the wall of the bladder, and has it spread elsewhere to other organs or lymph nodes. That gives us about the stage of bladder cancer. The T stage, how deep into the wall of the bladder the cancer has invaded. There are two staging system. One is when the tumor is staged as like 1, 2, 3, 4, and the T staging or the TNM classification, where is T staging, where TA, the tumor is limited to the mucosa. T1, the tumor has gone beyond the mucosa into the lamina propria, T2 into the muscle, and T3 extravesical, and T4 contiguous structures like the rectum or seminal vesicle or into the uterus. So this is the normal layers of the bladder: urothelium, then is the lamina propria, then is the muscle, detrusor muscle, then is the fat and the peritoneum. This is the layers of the normal layers of the bladder. So this is another picture of the same layers. This is the urothelium, this is the lamina propria, this is the muscle layer, and this is the fat, and this is the peritoneum, and this is the cancer, which is limited to the mucosa still. So stage 0, where the tumor is just limited to the mucosa, this is called stage 0. This is the risk probability of the bladder tumor according to TNM staging. So if the tumor is TA or low grade, there are 50% chances that the tumor will recur, and if the tumor has gone into the lamina propria, there are more than 60%, 50 or 70% chances that it will recur. One is recurrence and one is muscle invasion. If the initial tumor is TA, it is limited to the mucosa of the bladder, there are less chances that it would invade deeply into the detrusor muscle. But if it is T1, there are moderate chances that it would penetrate into the muscle, and if there is carcinoma in situ, there are high chances that it would invade into the muscle of the bladder. This is stage 1. The tumor has invaded into the lamina propria beyond the mucosa of the bladder. Stage 2, it has gone beyond the lamina propria into the detrusor muscle, so it is stage 2. Stage 3, it has gone beyond outside the detrusor muscle into the perivesical fat. This is stage 3. And this is the TNM classification. It's all given in your books, but briefly, TA, the tumor is limited to the urothelium. T1, it has gone beyond the urothelium into the lamina propria or the subepithelial connective tissue. T2 is divided into two, T2A and T2B. Basically, T2 is invasion of the tumor into the detrusor muscle. T2A, only the superficial muscle is involved, and T2B, when the deep muscle is, or the deeper half of the muscle has also been involved by the tumor. T3A mean that it has got perivesical spread. T3A perivesical spread is detected only microscopically, and T3B when there is perivesical spread into the perivesical fat macroscopically. T4A, when the contiguous organs are involved like the prostate, uterus or vagina, and T4B, pelvic wall or the abdominal muscle is involved. This is called T4B. Treatment: superficial bladder tumor, non-muscle invasive. When the tumor is limited to the mucosa of the bladder or the lamina propria, this is called superficial bladder tumor. The treatment is TURBT, transducer resection of the bladder tumor, plus minus chemotherapy or immunotherapy. Immunotherapy is when we give the BCG intravesically. Muscle invasive bladder tumor, when the muscle of the bladder is involved. There is one bladder sparing approach when the TURBT or the tumor is resected transurethral section of the bladder tumor, and then is the chemoradiation. Or this is called bladder sparing approach, or there is a radical cystectomy and urinary diversion. The whole of the bladder is removed and the ureters are then attached to the GIT into the gut. And partial cystectomy in case of adenocarcinoma, the partial cystectomy is done. As I have already told, that carcinoma usually develops into the bladder diverticulum. So radical cystectomy, it is the removal of the entire bladder, nearby local lymph nodes, part of the urethra and nearby organs. In men, the prostate, the seminal vesicle and part of the vas deferens are also removed. In women, the cervix, the uterus, the ovaries, the fallopian tubes and part of the vagina are also removed. So this is uterosegmentoscopy, when the bladder has been removed by cystectomy and the ureters are implanted into the descending colon on the left side. So at diagnosis, about 50% of the cases, they are when the bladder tumor is diagnosed, about 50% of the time or 50% of the cases are locally, it's limited to the bladder, and 5-year survival is like 96%. When there is local involvement, perivesical involvement, the 5-year survival is about 70%. When the regional involvement, like the uterus or the prostate or the seminal vesicle, contiguous organs are involved, the 5-year survival becomes even less, that is about 33%. And when there is distant metastasis either to the chest or lungs or to the bones, the survival is very low. Thank you very much. Thank you for the patient here.